Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Hi, and welcome to SpondyCast. I'm your host, Jill Miller. Our guest today is Angelo Papachristos. He graduated from the University of Toronto with a Bachelor in Science and a physiotherapy degree, completed his MBA from the Schulich School of Business, and completed the Advanced Clinician Practitioner in Arthritis Care program. He works to advance physiotherapy practice at Unity Health, St. Michael's Hospital, Toronto, in the areas of hip and knee joint assessment center, sports medicine, and rheumatology. His rheumatology focus spans over 22 years in early inflammatory arthritis, spondyloarthritis, seronegative arthritis programs, and osteoarthritis programs. He is also an adjunct lecturer at the University of Toronto Department of Physical Therapy, and he lectures extensively on medical and allied health professionals on the topics of spondyloarthritis and inflammatory arthritis. And he also has a keen interest in providing ongoing patient education via support groups and associations. I did it again. Angelo, thank you very much for joining us today. We're very glad to have you.
Thank you very much, Jill. Always pleased to be part of the SAA, and hopefully we can provide a great stimulating conversation, and always welcome to provide some insights.
Yeah, so we're going to talk today about physical therapy and managing spondyloarthritis. In terms of a chronic disease like spondyloarthritis, what would the goals of physical therapy be for someone that you have as a patient?
So just broadly, maybe we can get into it a little bit further on the specifics, but broad terms when discussing physical therapy, what do we do? What kind of value? We really simplify things. We really think of it in a few domains. It is a chronic disease that you're trying to look at managing over a span of decades. So we kind of look at it, how do we identify what we call impairments? Look at those impairments and try to improve of those, to try to improve overall function for the patient. And then trying to minimize overall disability, whether that be occupational, within the home, your environment, etc. So really, we're looking at identifying some restrictions or some impairment that patient has. Then we look at how we can optimize those to improve their function and then minimize long-term disability. 3 buckets, very simple, broad.
Okay. How does physical therapy help with improving mobility?
So that's the next. So it's very broad, and now it's getting into the specifics. So physical therapy, it's very, very broad statement, and a lot of times when we refer the patient or the families, a lot of the times come and say, well, what do you do? What is physical therapy? And a lot of times the referrals come from the family practice team or nurse practitioners or even the rheumatologist with physical therapy and a diagnosis. But what is that? What do we provide? And you can think of it in a few different buckets. Number one is a lot of patient education, education on the services we can provide, the disease, looking at overall disability, and how we can improve that client within the environment. What identify their needs and their goals. Right? That's a huge bucket. The next component of that is trying to implement the actual guidelines, the treatment guidelines for spondyloarthropathy. One of the big buckets in that, and its standard of care, is to provide non-medical therapies, and the biggest one is physical therapy, education, regular exercise, and smoking cessation. Those are sort of the overall arching principles and the recommendations for management of axial spondyloarthritis. The physical therapy component is really the stretching, the strengthening, the postural re-education, prescribing the correct cardiovascular conditioning program, making sure we guide patients on things not to do. For example, spinal manipulation is contraindicated. So it's a lot of education on what not to do and the appropriate things for that patient to manage. A lot of the times it's also providing things like ergonomic assessments, work assessments, home assessments. And that's one of the areas that both clinicians, medical professionals, rheumatologists, as well as physiotherapists and allied health forget. It's not about things that we just do to patients. It's also trying to optimize their environment to allow them to be able to function at home, whether they have a child, a sick spouse, or themselves, be able to work in their environment to provide income. A lot of the times, at least in Canada and in the US, insurance benefits might be tied to employment. Yep. So a patient that has the ability to function and provide, has benefits. And that's really what the overarching goals are, is how do we identify things to minimize the overall disability and impact on that patient.
So I have been through many cycles of physical therapy with spondylitis. And one of the really interesting things I think about, so I go through a cycle of physical therapy, and then because I'm having extreme pain, or maybe something's not working properly, or something's going on and my doctor's concerned that we need to take a look at it. So I go to physical therapy for 6 weeks, mm-hmm. or however many visits. I've reached a point now where I finish physical therapy. I kind of go back to try and getting back onto my normal routine of whether it's exercise or whatever. But then I often reach a point where I say, okay, I'm ready to up my game in exercise. Or how does a patient, and I know we're getting probably to one of the questions that's way down below that I didn't pre-read well enough. I'm usually better. It's been a crazy day, but how do we make sure that it really doesn't end, right? When we have a chronic disease, we got to keep tweaking and trying. Right. And I go through periods where I'm running and then my hips bother me. So I go to physical therapy and I stop running. Then and do you find that patients need to develop sort of whether it's a relationship with their physical therapist ongoing, or a relationship with the idea of physical therapy as part of life for what we're facing?
In your example that your own example is exactly what we try to articulate, at least to our residents and early clinicians, to try to educate them that if you're going to be treating in this population, you become almost a mentor, a coach, a life coach on exercise prescription and activity modification. It's not, it's completely different than when we treat sports injury patients. You have an Achilles or a rotator cuff or some other thing where you want to go in for your 6 to 10 sessions, and it's one treatment and you're done. With chronic disease, especially with spondyloarthropathy, we forget that it's not a one and done. It's an assess of baseline, right? Document exactly where you are at this stage when you got diagnosed. Do a baseline fitness assessment. Do all the metrology, and the metrology is just measurement. And a lot of the time we're lacking because the measurement of how the person was at time 0.0, when you come back at a year or 2 years later, it's very hard for you to remember, how much mobility did I have in my neck, or what was my cardiovascular, status at that point. So I think having that documented and you going back to the same team or the same clinician, then to reassess you and say, yes, you've decreased here by 10 degrees or 20 degrees and your function or your strength has decreased. Therefore, you can push the patient forward at an appropriate interval. Yeah. Postural exercises, flexibility, core strength, that's a continuum. So as you move through that continuum, you might need reevaluation and, again, up your game. And another thing and it's our fault as medical professionals, what we forget is patients age, right? Sports and hobbies and recreational activities that you did when you were in your 20s, which, might be basketball, softball, other activities, change as you age. Your preferences change. When you're in your late 30s or 40s, you might start weightlifting or running or bowling, and then you start getting into cycling, and then we get into Pilates, and then eventually everyone's golfing and walking for exercise. But when you go to a clinician, your rheumatologist, your physiotherapist that's treating you, it's do this set of core exercises and do this, Pilates or yoga, and then we're done. And I think that's a concept that we're moving away from.
Yeah.
Patient preferences change over time. Your situation at work and home changes over time, right? Your preferences to physical activity and ability to do those change over time. So therefore, we need to change over time and prescribe the right form of exercise that's conventional, as well as sports and recreation. And why do I say sports and recreation? Because if we don't implement things that you find interesting and fun, then you will not adhere to that program, right? There's a certain core exercise that I think is beneficial that we treat and manage spondyloarthropathy, range of motion, cardiovascular exercise, etc. But honestly, that can get boring. So
Yeah.
I need to facilitate that and say, Jill, you're interested in, yoga versus aqua fitness because you can't swim. Well, aqua fitness might be a therapeutic pool, might be one of the recommendations, but if Jill can't swim, there's no point really talking about going to a swimming program, right? So I think as professionals, we need to get to know the client, spend a lot of time with that education, and then be willing to work with you to modify those activities.
Yeah, I think that's an excellent point. So, and you made me come up with two questions. We're totally in the weeds, by the way, so this is great. Two questions though, right? You come up with, so as an example, I was in physical therapy, was released back into the wild.
Yeah.
Decided to start strength training again, and I'm like, I can't exactly deadlift 85 pounds anymore that I could a year ago.
Yeah.
So I kind of like picked up a couple things, and then like I emailed the physical therapist and I said, hey, what do you think I need to work on specifically to be able to get to where I'm working on deadlifting again? And I think those are that ideally is the relationship. And there's often this, because I went through a period where I refused to go to physical therapy because I was like, I can do whatever I want in the gym. And I felt like, but I think that this is where we have to get into, it's the management of the disease as, right? How do you manage the acute versus the chronic? Yeah. And the acute would be when you need 2 or 3 days a week of physical therapy for 6 weeks. Right. And the chronic is just every day, right?
Yeah. And you sprained or you had a muscle or myofascial pain from doing an activity, and that needs a short intervention, a short period of time of intervention. And that might be a course where you're going. But your example about deadlifting, coming in, and that's an activity you choose that you want to go into, which means I need to bring you in and assess to make sure your lumbosacral spine has enough mobility, your hip, your glutes are firing, etc., to be able to modify that so you are able to do the activities safely without causing injury. So your deadlifting example was an excellent point of discussion. So if you came to your therapist and said, I want to go back to deadlift, and it has been an activity I haven't tried, it's a new activity, the role that we would play as physical therapists is to bring you in and to ensure, number one, reassess to make sure that you have enough mobility in your lumbosacral spine, in your hip girdle, etc., and glute firing, muscle strength, to be able to do that activity with proper form to not injure yourself, right?
Right.
And, after assessment, you may have had some restrictions in there, or, that's a discussion to say, listen, Jill, you don't have enough strength in these muscles. You don't have enough mobility, articular mobility in the spine or in the hip. And it's my judgment that we need to work on some mobility first, some range of motion, maybe stretch out the Achilles. You go into a deep squat, you might injure that and get increase your enthesitis, and you might become symptomatic. And then maybe we do this slowly, modify the number of repetitions, modify the weight, and have that discussion. And I think that is a perfect example of how you choose to do an activity. You come to your therapist, and it's my job to assess and modify it so you don't get injured.
So that's really that's the long-term management strategy.
That's the long-term management strategy. Early in my career, and I think in the treatment paradigm, we would say, don't do these exercises, or don't go into hockey or karate or high impact things, because really your risk of fracture and trauma and fracture is high. So we would avoid all these activities and play it safe. Now, I may still say that if you're completely fused or you don't have the restrictions in there, but our role really as professionals is to come in and say, you've identified that you would like to participate in an activity. That means that Jill would be more likely to keep this activity for the long period of time, and then you will get benefits from cardiovascular, strengthening, mobility, and exercise really has the added improvement or benefit of physical well-being, improved psychological well-being, meaning that it helps with depression and sort of that all that soft sort of non-MSK related conditions that you get the benefit. So right. Our role is to come and say, you've identified that you would like to participate in this. My role is to figure out, can you do it safely, or how long or how much do we have to work to get you to that point, right? And that's the relationship. So it's not coming in once a week for ultrasound or acupuncture or treatments for a myofascial injury. It's getting you to the point where you can safely participate in the activity you chose, and to do it in a way where we can continue to monitor you over a long period of time. Because my goal is to say, Jill, I would like you to continue with your deadlifts or your yoga over the course of 1, 2, 3 years to get the benefit, not just do it for 6 weeks, get injured, and then never come back to see me because you had a bad experience.
So yeah, okay. So let's pick back up on this idea of like physical therapy as an enabler.
That's right.
And a risk mitigator, right? Yeah. Like reduce the risk of you getting hurt as a patient, but enable you to have the life you want to live.
That's exactly. Our job is to identify the impairments, and most of your audience probably won't have a clue what that means, but they do understand improved function and limit disability, right? How do I keep you doing the things that you want to do and minimize that the impact of the disease from an MSK perspective, musculoskeletal perspective, in your environment and work? That's basically the bottom line, right? And then the rheumatologist, job with medication, etc., treatment of the disease is another component, and the two together hopefully gives you the best outcome.
And as you're working through this, do you look at the changes in medications to what's going on in the treatment plan? If a medication changes, do you maybe expect that the patient may experience something different?
Yes, good point. Excellent point. And I think that's where the communication between the patient, referring physician, rheumatologist, and sometime in the community, it's depending on access, might be just a nurse practitioner or a family practitioner. We have a very close relationship because a lot of the treatment paradigms are this treat to target perspective. You might be put on, an NSAID or a biologic medication, and then the rheumatologist says, try this 3 months, 6 months later, and they're going to look at response, right?
Right.
And if I put you on a program and say, Jill, you're going to go back to these deadlifts, and you cause a substantial amount of pain and discomfort in your low back and your hips and your your knees and your ankles over the enthesis, you go back to your rheumatologist after 3 months of starting on biologic therapy, and you have a flare. You're painful everywhere. Was that the fact that the medication was not responding, or the fact that Angelo put you on a too aggressive deadlift program?
Right. So causality.
Exactly. And it's very difficult for the patients to think about that, but it's very important in our perspective. So what I would like to say is, the more information you come back, you're starting a new medication, or they switched medications, or for example, in women, if you're planning pregnancy and you have to come off a biologic or a treatment,
Sure.
not making a lot of changes and maybe saying, listen, let's see how you respond when you're being switched, or to, you're doing planning for pregnancy, etc. Maybe we should switch the program and not start this right now. So your rheumatologist and the rest of your team has a better idea how you're responding to the medication. Once you're at that dose, you've had that 12-week course where they can really see the effectiveness of that medication and then reinitiate.
Right.
And I think that's critical, because you'll go back into clinic, and the risk is that you had such a big flare because I started you on a really aggressive program, that the rheumatologist thinks that you're not responding to that medication, when really it's the fact that you've gone in, you're working a physical job if you're a construction worker, and I've given you an exercise program, and you go home and you have to do your gardening now in the summer, and all these are conflating factors. So you have to look at the big picture. You have to look at the entire spectrum of everything, and then we have to fit in that therapeutic exercise where it's appropriate and at the dose and interval that it's appropriate.
And maybe sometimes don't change too many things at once.
Exactly. And very slow. This, we try to be lifelong friends or life coaches in this, and really, it's okay to say, let's not make any changes for the next 3 to 6 months. Yeah. Your mobility, your muscle strength, your cardiovascular endurance is not going to dramatically drop off the cliff if we do nothing for 3 months, right?
Yeah.
Maybe take it back to do just the range of motion, or Pilates or a yoga program a couple days a week, and do just general fitness like a walking program, and then revisit when you're on a stable therapeutic dose, and then reinitiate it, right?
Yeah.
So I think again, if there's any loss in or increase in disability, for example, you're taking more time off work because you can't manage, you're not able to look after your loved ones at home. You're not able to do things that you need to do because you're having significant flare or intolerance because of medication and exercise. I think it's time for us to all reevaluate and adjust it. And I think that's why the communication between the client is more than just coming in there for that 6 treatments or 8 treatments of ultrasound or TENS or pain modalities, and you're gone. It's building that how much, when to add, when to reduce, and when to modify.
Yes. Well, to quote one of my favorite Canadian authors, in 12 Rules for Life, which is, we're looking for meaningful, not expedient, right?
Exactly.
And I guess this is probably a yes or no question, but sometimes it gets worse before it gets better a little bit, right? There's this difference I find between where my muscles hurt after too much exercise versus what is related to something that could be turning into a flare, and kind of knowing your body a little bit. Is that accurate?
That's very accurate. And sometimes it's frustrating. You've lived with the disease for a long period of time, so you sort of know, your body, and when the flares are coming, or what is that stiffness or that pain or that sensation. Is it strictly just a sprain or doing too much, or is it the disease? But for patients early on, you might be going to your rheumatologist and say, well, you're in disease remission, blood work looks fine, but you have pain everywhere, right? And teasing out what is disease activity and what is from living day to day, doing your occupation and doing exercise takes a while, and for the patient and the clinician to really hone down and be able to say, well, this is from disease and this is from you just pulling out weeds for 3 hours and doing gardening,
Right.
So I think it's the conversation has to be ongoing, and over time you get a good judge of how much exercise is causing the culprit or activity, and what is really a flare.
Okay, so I do have a question. We'll call it a non-empirical piece of research that I've been collecting just as I talk to people. So one of the things that I have asked I don't know, we'll say 50 people and a couple practitioners is,
Okay.
do people with spondyloarthritis, particularly those that have it in the SI joint that it's prevalent, do they tend to be people who overprotect their back and maybe overuse their hip flexors? And maybe this isn't your experience, but I have a theory, and I'm curious on your, because one of the things I find that a lot of us struggle with is when we go to physical therapy, when we've had a stiff back our whole lives that we're trying to protect, we go to into a program and someone says, well, just strengthen your core.
Yeah.
And I know, as the disease has been for me, and this is why I started asking anyone who would talk to me about their experience, was, do you actually know when you engage your core? And it's like, well, not really. And I will speak, I just from asking people, do you feel core work when you leave a yoga class? And they'll say, no, but my back really hurts, right? Or I wake up in the middle of the night and my hip flexors are on fire. Yeah. And I just have this theory that there's a population, maybe with or without spondyloarthritis, that we don't actually, we need like much more basic one point lesson on, this is what it feels like to engage your core, and here's how you can tell it's happening.
Yeah.
And I'm just curious on that, because core, I think, is obviously it's key to.
Yeah. And hopefully you've gone to a practitioner that will spend that one-on-one time.
Yeah, I have.
Totally you how to activate the core. And it's very challenging. So you brought up very interesting points. So yes, you should be able to feel and activate and even palpate some muscles that we want. Now, your hip flexor is typically what happens in posture. When you will splint your spine, let's say, into flexion because you have pain.
Okay, so what does flexion mean? As you're saying that word, some of us don't know.
It's when difficult to. Okay, so just imagine your tailbone or your butt goes forward and you're in a flex position.
Okay, so you're at a 90-degree angle.
Yeah, just slightly.
Okay.
This is kind of hard to describe it. So what happens is your hip flexors in axial spot, you typically will go into a shortened position, as do your hamstrings, and it forces your pelvis into that anterior tilt. So you feel stiffer. So it's very difficult from that shortened position to activate those muscles that tip your pelvis back. And that's what we want you to do.
This is
so
mind-blowing.
So what we need to do is identify, those are the impairments. So we identify that maybe your hip flexors are short and your hamstrings are short and not the right tension. And we have to give you specific stretching exercise routine to lengthen them. And then we work on the core to optimize, right? Because think of it as two tight ropes over there, and it's controlling your pelvis. So we need to identify that one muscle is short and one muscle is weak. And it's usually the glutes that are weak and the hip flexors and hamstrings are short. So it tips your pelvis forward, right? So this is the whole point of going to a practitioner, and you're looking at me on the screen. Like, this is an aha moment.
This is an aha moment, because I've been
a basic 101
physical therapist since I was a teenager, and no one has ever said to me, this was what could be going on because you have the condition you have.
That's right.
Okay, so I'm going to admit my question was somewhat selfish, but I think it applies to a lot of us.
I've
just come out of a year of trying to figure out how to let my hip flexors be a little more loose so I can engage my core. And I literally have found my core in the last month for the first time in years.
It's hard. So if you have two areas that are fixed and you have no movement. Now, if in certain patients, you might have fusion, right? And our goal is early on treatment is to, these posture exercises and mobility and flexibility are to continue to make sure that the joint is moving.
Right.
Medication is to prevent long-term sequelae of the fusion, right? So the goal is to maintain that. And then the medication sort of suppresses that, hopefully, that disease, so you don't get that spinal fusion. Now, if your spine is not fused, if you splint or brace yourself in a position
Right.
over a long period of time, you will shorten those muscle groups and other groups will get weak. That's the reason to go to physical therapy, right? Identify the impairment, work on the specific program over a period of time. Now, you brought up a very good point, and I'm not sure if we're getting into that. At least in Canada, and I'm sure in all of North America, the training for allied health, whether advanced practice clinicians or just sports physios in the community, chiropractors, osteopaths, in the undergrad program, even the graduate programs, we get about a week in rheumatology of training, right? So I think a lot of awareness on the condition and how to treat it and manage it is something that SA and other organizations are really focusing on educating clinicians as well as patients. So you don't have this experience, right? Where you've gone, 20 years with a condition and it's strictly biomechanics that anyone dealing with rheumatic disease should be able to articulate to you and get you on that program.
Yeah, like you saw me. It's literally a jaw-dropping moment, and there's not a lot of jaw-dropping that I've found about this disease. I thought I knew everything, but this is amazing because, and I guess I will say something I've explored is I think in order to make progress, I've had this conversation in different facets of things I've had my fingers in. Women tend to need to know the process by which something occurs. Men don't always need to. And I think it's just this, maybe it's a difference in, as we call it, conditioning but if I go to the bank and the bank declines me for a loan, I want to know why. Yeah. Typically women want to know why, and men
just go to another bank.
And it's interesting because what you just told me made me think, like, as I move through this, I'm going to visualize like what's happening in my body. And I've been trying to do this, and it's probably why I unlocked a few things, but I was like, man, I can't even engage my core because everything else is so messed up in my hip flexors and I can't get my hamstrings long enough. And now thank you. For anybody else who heard that, thank you. Okay, so let's get out of the weeds just a tiny bit. Sure. Maybe not so much in Canada, because I know you have a different health system than we do, but potential barriers to accessing physical therapy for people with, whether it's spondyloarthritis or a different chronic disease. Do those barriers exist, or how does somebody make sure that they're getting access to what they need for their care?
So little caveat, the systems are a little bit more similar than you might believe. Okay. So you do have access to, great care up here in Canada. You'll see your rheumatologist, you see your physiotherapist, but having specialized centers or clinicians that are trained, like we just discussed, in this rheumatic disease, there's still barriers of access because patients have difficulty identifying or who to go to, right? So that's number one. Having a clinician that sees a lot of patients with spondyloarthritis or inflammatory disease is challenging. Getting to know who does what at what center is still a challenge. I think the number one challenge for patients is just identifying where to go just to have a basic conversation and get those baseline metrics. And I think what you need to do is really ask your rheumatologist or your nurse practitioner, your family health team. They know, patients know. They come back and report, I had a great experience with this clinician at this clinic, and they'll give that feedback to their rheumatologist. And then when you ask them, they will say, go here, because that's where that patient has good response from. Yeah. So asking the people that are the clinicians that deal with arthritis for an arthritis recommendation versus go to a sports clinic or a chiropractor or physiotherapist that does, rotator cuffs or ACL reconstruction rehab. Right. So getting to the right person is number one. Number two is access to care. For example, the recommendations, the ACR recommendations, as well as the EULAR recommendations, ASAS recommendations, are physical therapy, group exercise, as well as pool therapy. Right. pool therapy, aqua fitness is very beneficial. But if you don't have access, you're not in proximity to a pool, it's a non-starter. Even here in Canada, we had the whole COVID thing, just like you guys down there. And a lot of the public access pools were shut down for an extended period of time and not reopening, both because of cost and, liability and group costs. So that takes an option away from that patient unless they have access to a condo pool or a private access pool, right? I think the third biggest is cost, right? Physical therapy, whether you have private coverage, is an issue, which is why we try to keep patients employed, because a lot of the time, at least in the US, your coverage is tied to your employment. So having to have the capacity to pay for therapy is critical. Now, we had a brief discussion that I don't think it's beneficial to see the physiotherapist or allied health professional every week for months on end. And I think that just that whole discussion with them is mind-blowing, how much money you can spend on professionals, right? Myself included. And listen, I'm a capitalist just like everyone else. And if you go to a physical therapist, our tendency is to want you to keep coming back, right? Because I make money off of that. But the treatment paradigm for a chronic disease is assess, put you on a program, reevaluate 6 to 12 weeks later, and continue that relationship over time. So your overall cost, let's say in a year, is substantially less than if your typical treatment program post rehab for surgery, etc.
I like it. Maybe we should start a new physical therapy.
Yeah. So I think, listen, there's incentives up here, incentives down in the US as well, costs. But I think when you look at it, giving you a program, coming back 6 weeks later, reevaluate, or 3 months, spending that insurance money on maybe an ergonomic assessment for work to make sure you have all the assistive devices, proper chair, proper computer setup. It's our job to really maximize, and get you the right treatment at that cost, right? And if you can't, then it's putting on this the right program or access programs that are publicly available. And for example, I don't know if we're going to discuss this, but I'll bring it up now. SAA has fantastic, entry-level programs on their website. You have an exercise brochure that's on there that's been vetted by clinicians, that everyone can get started day one on how to perform a great stretching program. They have videos, back to action, again, that are available for patients on the website, where they have a strengthening, a stretching component, yoga component. So all of these tools are available at no cost, right? The Europeans also NAS have a very good PDF, as well as an iPhone app that shows you the exercises on. So there is really, I think cost should not be a barrier here, because you can have access to materials that are very good and vetted by clinicians available on these sites to get you started. And then maybe you come back after you've done those programs for 3 to 6 months and just get the tune up like you did here with your deadlifts, right? You'd come back to me after doing this for 3 months and come back and see the therapist one time for an hour assessment, and I modify that, send you off. You come back in 6 weeks and see me. I think building that relationship and that trust over time is the approach that we take now.
Yeah, and it's the tune-up, right? This is the long game for us.
Yeah.
Okay, so let's pivot first.
It's a long game for me too, Joe, because then you'll come back to me for decades versus
right. It's customer lifetime value is what that is. And I'm sure there's somebody tracking that somewhere. How much is she worth to me in the next 12 years? So the question I think that's on a lot of people's minds is, okay, we'll say, I think when I go to physical therapy, I think after insurance, it's like $88 is my copay. And that's going to vary for everybody.
Sure.
Depending on your insurance plan, or maybe it's 50. We'll just use 50. And so I'm spending that, we'll just say 12 times a year, $600 a year.
Yeah.
People often look at me because I have like multiple gym memberships, and they say, why would you pay $80 a month to go to a gym? And I'm like, because $960 a year is not, to me, I spend more than that at Starbucks for sure.
That's right.
But the other benefits I think of when I go aren't, what is it costing me in dollars, no matter the currency, but what is it giving me in health? And am I avoiding larger costs down the road? And you may not know the answer to this, but am I avoiding fusion, permanent damage? What is that investment? Especially if you look at it, I like the way you look at it as the long game.
Yeah.
And I write the plan for improvement or maintenance, right? Or system. You have to maintain your body is your most valuable asset. You have to manage it, maintain it. It takes preventative and ongoing maintenance. But what is is there some sort of known benefit to ongoing physical therapy when it comes to reduced disease activity or fusing?
Okay, so that's a very
big question. Sorry.
big question, a little tricky and nuanced. So I will say, in the long run, I get this asked a lot because some patients really want to avoid conventional medication strategies, wanted to go the alternative medicine route plus exercise. My answer to that is that we're complementary, right? The physical therapy alone / complementary therapies are just one component, will not prevent sort of that damage that the disease will do over time, right? The inflammatory component, the articular damage, the potential organ damage that happens, right? Cardiovascular events, all those events will happen over time. So the drug management is to help prevent that. Now, what does the physical therapy and exercise component do? It allows you to be able to function better with less pain, with a better and healthier mindset, right? Because we have the psychological impact. It allows you to be able to have better cardiovascular endurance, to be able to do the things you want to do, right? And I think the combination of the both gives you the best chance of requiring maybe potentially less medication for your symptoms. And that's the way I put it. What I do will not prevent long-term, CRP from, decreasing, etc.
Right.
But I really don't care. Patients don't come to me and say, my inflammatory marker, CRP, was 37.5, and therefore do what you can to help me reduce that. Patients come to me with, I can't lift up my baby from the crib over here. I can't lift my groceries out of the car. I can't, go play with my kids. I have pain in my ankle, my knees, my hips, my shoulders, and my neck. I can't turn to drive my vehicle anymore. They're function in pain, right? So how do we optimize function in pain to allow you to continue to do things? And what value do you put on that, right? We're talking about costs. So if you're not able to drive your vehicle because of restrictions in your neck, and you're an Uber driver, or you work for UPS down in the States, and that is, what's the economic loss versus spending, a couple $100 or your own time doing exercises, a video program that the SAA has online. Only the individual can sort of weigh the pros and cons. I think the economic value is much, much higher if you do not do the physical therapy and exercise in combination with the potential medications you may need, right? The goal always is to maintain function, reduce disability for the minimum amount of medication that's required, right? That is always the goal.
Yeah.
And if for some reason you've lost efficacy of that medication and you need to move on to something else, something better comes out in 3 to 5 years, they're always doing new research. It's to maintain you on the minimal amount of medication to keep your level of disability at that same level, right? To allow you to function, or else what's the point, right? I can put you on a medication, drops your CRP down to normal, but then you're so deconditioned and you have ongoing pain from long-standing damage that you're still not functioning.
Right.
So it's, but I am biased. I'm a physical therapist. So I believe that the economic value to the client is much greater than hopefully the output cost or the outlay that they will put out there.
Yeah, I think that the way I would think of that, even on an individual basis, is physical therapy, various different complementary therapies, medication. Those are all our tools, right? That's like our hammer and our screwdriver. We have to put, as individuals, we have to take all of our own personal variables into a bucket and kind of determine our results. Or like, if I say I have these 4 tools at my disposal, I want to change this, but these are all my variables, right? I'm a mom, or I have a job, or I can't do a job, or I often complain to my team. They always want me to return emails. And I say, when I type too much, my wrists flare.
That's right.
And I don't want to have carpal tunnel surgery. So, but I do know if I go strengthen my wrists and I'm not emailing 8 hours a day, hey, I'm a much better human being. So we have to look at our own variables to understand which tools work and where and what's most beneficial.
Right. Bottom line is very individual to the client, to allow you to do things that you want to enjoy.
Yes, I love that. Okay, so we better wrap because we've talked for almost an hour, other than my technical difficulties. This has been fantastic. Let me ask you this. What one tiny piece of advice would you give to anyone across the board with spondyloarthritis?
Oh, that's tough. Do your research. Find clinicians, your rheumatologists, and their associated team that you trust. Follow their advice, but be open to communicating with them what your goals are or what you're sort of envisioning, right? Make sure that you give me that information. And then our job is to assist you on that path. We're not mind readers. We all come from different perspectives. The rheumatologist will hit you from the rheumatology perspective, and we got our blinders on. The physio will hit you with the physio blind. The yoga instructor hits you with the yoga blind.
Yep.
And I think you have to take charge of your well-being, right? It's your body. It's your pain. It's your discomfort. It's your, activity within the community. And I think you have to articulate that. And if you're not comfortable with that clinician, move on.
Yeah,
I won't get offended, or anyone else won't get offended. And I think a lot of times patients, and it might be due to access, I think a lot of times patients fear that by voicing these concerns, they'll get cut off or their clinicians. And if that happens, it wasn't the right clinician for you.
Yeah.
That's my advice. We build a therapeutic relationship with every client, and it's our job to make sure that your goals are met. And it's our job to tell you if it's a bad idea to do something. And sometimes it is. I will tell you, listen, Jill, I do not think that this is safe for you to do. And I have to be able to articulate that and get you on the path to be able to do something else. And that's where the trust comes between the clinician and yourselves.
Yeah.
It's a joint effort. It's a joint effort. And it's not me prescribing down to you or the physician prescribing down to you. It's how do we bring everyone at the table together, all the team players, and try to optimize you. That's the biggest advice that I can tell you. And
yeah, I'm going to land on this because I think what you're saying, I have this framework in my head of any relationship in your life, right? It can span whoever it is. You have to be willing to talk about your values and how you enjoy life, where your boundaries are at, and what you're afraid of. Like values, boundaries, fears. that framework, if you can have that with whoever your practitioner is or other relationships in your life, you become a much happier human being.
I think so.
So, all right. On that note, I want to do this again. I'm gonna go back to deadlifting, and then we're gonna talk about my next phase.
Lifelong client. I'm gonna get you for the next 3 decades.
That's great. Next time I'm in Leslieville, I'll be there. I'm gonna come and visit you.
That's an open invitation. If you want to come down, the hospital's 10 minutes away.
Yeah, absolutely. I'll probably be up there. I've got quite a group up there. So I'm hoping to make regular visits. But thank you so much. This has been amazing. And I really appreciate your time and like your passion around this too.
No problem. Thanks for having me. And thanks to SA for holding these events. I think great organization. And I think the more information, stimulating information for clients and clinicians together, it builds better outcomes in the end for everyone.
Yeah, totally. SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie. Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.